Hello everybody, my name is Trixie McAree. I am the National Lead for Continuity of Care in England, and this slide set has been prepared by myself and Jane Sandel. And what we want to share with you today is how midwifery continuity of care went from a concept into being a viable model of care. First of all, if you want to bring about a change, you have to make case for change. You need to look at what the problems are at the moment, which I will go into with you in the next few slides, provide evidence, investigate solutions, and then recommend an overall solution to your problems. So what we looked at, and particularly Professor Jane Sandel over many, many years, has done a lot of research into the best way of providing maternal and child health and what makes a difference to people. But we didn't just look at maternal and child health. We looked at models of care. We looked at research that related to workforce, such as Michael West's work. We looked at global health. So we reviewed the work that's been done by Anthony Costello, who reduced perinatal mortality in the Indian subcontinent with his relational interventions. We looked at primary care. So we looked at work done by Barker, for example, that looked at systematic reviews that changed mortality in the general population by providing a continuous relationship between the GP and the general public and the people that use that service. We looked at anthropology, and then we also looked at local and national audits and reports, such as the CQC, such as Embrace, to put together a full understanding of where we are now and where we would like to be. So the context in England is, for at least 15 years, the spotlight has been on maternity services. Back in 2005, Northwick Park maternity service was the first one that went into special measures. It hit the news. It was a great big scandal. And essentially the conclusions were around the culture, the competence, care planning, risk assessment that went on in that organisation. But as we've gone forward over the last 15 years, even though we've put in many layers of you must do this, you must do that, how should you be trained, what are we going to do about it, so many different things, extra burdens on both midwives and indeed doctors, we haven't changed anything. And we've come to 2020, the Ockenden report, and actually the same issues are coming up over and over again. Now, a wise man, Albert Einstein, once said, insanity is doing the same thing over and over again and expecting different results. But that is precisely what we've done within the context of our healthcare service. We understand a hospital model, and therefore we've stuck to a sickness and health hospital model to keep trying to fix it. And actually, as we've seen, nothing has changed. So now, since 2016, we have made the case for an alternative approach. And the key data sources, as you would expect, are from meta-analysis. So we look at Cochrane reviews at the gold standard for understanding care and work. And what they tell us is where women are cared for by a team in a continuous way, where there's a relational intervention, outcomes improve. And that includes things that involve safety, and those involve things around personalization. What it tells us is you are less likely to lose your baby, you're less likely to have a stillbirth, and you're 24% less likely even to have a preterm birth. And these Cochrane reviews have been done more than once. So you can see there's a 2018 review and a 2020 review that also bear out the same findings, that if you want to save babies' lives, providing care within a continuity model is the way to do it. We also looked at the adjunct data sources that I mentioned in the previous slide to bear that out. So we looked at what did exactly Barker do. We looked at things like what Professor Kai did up in Liverpool, looking at how we manage health inequalities and how we manage diversity, and how that feeds into the fact that we get less equal outcomes across our populations. We also looked at epigenetic effects. So, for example, there is lots of work that tells us that when you get that mother and baby dyad healthy, the resulting outcome is that that person grows up and lives a long and healthy life and is less likely to drop dead, say, of a heart attack age 60. We also looked at mental health and well-being, and we know that where women are mentally well, less anxiety, less depression, not necessarily the off the scale really severe mental illness, but if we just look at general terms, women who are well read to their children, and those children then go on to school and do much better at school. And so we had to draw all these things together and say, we need to do something that provides this. We also looked at the Care Quality Commission and ongoing reports to understand what had gone before in this area. So we dug into the 1919 survey, so it was before COVID, because we didn't want to have that muddling up many of our results. And we looked at the data, and what we could confidently report is that the clinical quality of care, 11 times out of 11, was better as perceived by the women who reported this care, who got continuity and was cared for by a midwife that they knew all the way through their process. They got better respectful care, they felt they were more informed around decision making, and they felt they had better access and more responsive care. So what that tells us is the evidence points to this is the way we should be giving care. And it also tells us that when women have received this care, they get better outcomes. We also undertook a survey ran by the Maternity Services user group, and they came out unequivocally with the answer: we want to be cared for by the person we know, because it has such a positive impact on how we feel about the whole process. It's really important. And then finally, this July, we had the report from the Select Committee on Safe Maternity Care, which is the government's committee, and they took information from a whole variety of sources, and they looked at how we improve maternity safety. And what they concluded was we absolutely need continuity of care as a model of care. It is the appropriate and the right thing that we should be doing. Unfortunately, we're not doing it quickly enough, but we are doing it, and we will get better as we move forward, I am sure. So in 2016, it became policy. In 2019, it became part of the government's long-term plan, where we said by March 2021, most women receive continuity of the person caring for them through their pregnancy, during birth and postnatally. Now, obviously, since 2019, when that report or that policy came out, we've had an epidemic that has been very terrible and very difficult for all of us across the world. So we have slowed down and changed the timeframes around that. But this week, we're actually delivering the midwifery continuity of care at full scale guidance, which will help organisations deliver this. And we can share this with anybody that wants it after this seminar, if that would be helpful to you. We didn't just do this on our own. We used a wide range of stakeholders. So you can see on this slide how many different people were involved. There was a Better Births Committee, there was a Maternity Voice Partnership, which is service user groups, there were road shows, there was an expert reference group that is still in place. We held roundtable discussions, so people that had objections and concerns could come back and share their worries, and we could address them. We did lots of learning from each other, and we did early adopter groups, which didn't always go well, but they told us what we shouldn't be doing, and actually have told us now the best way to provide the model of continuity of care, and what will work, how will it work effectively, and how you can operationalise it. So what did the government do to help us? What kind of support did we get? Well, it came in various different ways. So firstly, Health Education England over a 3-year period provided £1.3 million so that training could be provided for this, and it was evaluated by Harris et al. In 2020. And the reflection from this was that it was helpful for the workforce engagement. There was also investment in leadership. That meant my role came into being at that time, but also we built tools that would help organisations deliver continuity in a safe and sensible and very clearly planned way. We even got charitable involvement. So a patient safety learning group supported me in making a video that would help people understand how to do this. In addition to this, transformation funding was allocated, and you can see over those timeframes, money was given to support transformation. And then finally, because the epidemic, COVID-19, shone the light on the fact that actually we didn't have the right midwives in the right place, and we were short of midwives, an additional £95 million were made to ensure that actually we've got the staffing right in the first place. And then finally, there was some safety and personalisation incentives given out, which is the scheme that we operate in England that says if your service is safe and you can demonstrate you're doing things that contribute to safety, you get money. And continuity of care is in that package, because it is absolutely vital that we support planning and execution of this process. So you may well have a plan, but you've got to get over that bridge to success. And so we've given as much as we can do, and we're building on that all the time to make sure that there's good engagement, communications, teams are prepared, people are trained appropriately, there's a standard operating policy, you've got a place to see women, equipment, how you're going to pay the midwives, and ultimately an evaluation of all of this is all in place. And we focus on making sure that we've got all of that in place to do this. So all of that sits in the NHS EI toolkit, NHS England and Improvement Toolkit. So you go onto the website, and the first thing that you'll see and you'll understand is that we're looking at staffing the women and not the building. The whole process is around making sure that every single woman has a midwife at any given time and is supported by the wider team. And what this gives us is it gives us security that we know that we've got the right people in the right place at the right time. And we can categorically tell people we're safe. And what happens in reality is that for most organisations, it means 60%, 50 to 60% of midwives are working in teams and the remainder are working in the core. And so we have a safe core as well. In addition to this, we've said you don't want to go around setting out your teams willy-nilly. What you need to do is have building blocks that make sure you don't only implement continuity teams, but you're also able to sustain it. And on this slide, you can see all the elements that need to be in place. It starts off with safe staffing, but you absolutely have to draw it out. What would default continuity look like? Where is everybody going to go? How are we going to do it? Do we need more than we've got at the moment? And in most cases, the answer is no, you don't need any more midwives to deliver this model of care. Occasionally you do, depending on specific situations. You do need to make sure that you've trained your midwives and that you've put in time for team building, because we're asking midwives to work in a very different way to the way they're used to working, and therefore they've got to have time to think about that and what does that mean to them. Now, this isn't about midwives doing midwifery only care. This is about all of us working together in a new way to have a better working culture, better communication between ourselves, and therefore we've also got the linked obstetrician who doesn't pick up the women in that team specifically, but that person has a relationship with the team to ensure that there's a good referral process and good multidisciplinary team working in between everybody. So where are you now? You may well want to ask me, and you might not know this, but there's approximately 600,000 births in England every year, and about a sixth of them are placed on continuity teams. That means almost 100,000 women are receiving continuity of care in one shape or form or the other. In March 2021, there were 371 teams in place compared to 347 in October 2020. But the good thing is about this is that those teams are being placed where they need to be. So in areas of deprivation and areas where there are Black, Asian and mixed ethnicity women living. And you might say, why are you signalling out those people? It's because those are the people that have the worst outcomes according to the Embraced report. So we're asking trusts to place their teams first and foremost in those areas and then building out from there. And you can see from the graph in the corner that there are a few teams, maybe 70% of trusts are beyond 35%. The majority, though, are running at around 10% at the moment. But this is moving forward all the time, despite the pandemic. There are some really lovely examples for you of good practice, and I would like to just pick out two out of many I could have picked on. Milton Keynes is the one trust. They have now, I believe, 6 teams in place. They had 5 even when I was writing this slide deck. And their data you can see in the infographic in the central slide. And not only are we getting improved outcomes, we're also seeing there's a really positive effect on the midwives. So there was a 52% reduction in sickness after joining the case loading teams, which is amazing and fantastic, and it's what you want to see. And what we have across the country is midwives reporting that they have a better work-life balance after working in this model of care, and we are just working at the moment to formally evaluate this and write all this up in a much more formal fashion. Another example is County Durham and Darlington, where they used the toolkit to plan their transform model of care. And they did lots and lots and lots of engagement, which was the way to get things rolled out properly. And as a consequence, continuity is being seen as a solution to the problems, and it's being seen very positively. So finally, what was the process and the impact? You need to know where you're going. That is the first thing. If you don't know where you want to go to, you'll never get there. So that slide at the bottom, which says communicating the vision, describes what it's got to look like and how you want to go there. You then need to have a clear understanding of where you're at the moment, and you need a clear plan as to how you're going to get there. Our lessons learned are at the beginning. We just didn't know how to do it, but the toolkit's got around that. The second issue is about making sure the right staff in the right place at the right time. And the third thing is that we need to bring the midwives on the journey. And that's what we're doing. And we are hoping that we will get to full default position over the next couple of years. Thank you very much for listening.